Okay, welcome everybody. We're starting our next session, which is on, again, the left atrium clips and closure. We're going to do a couple of quick slides to remind everybody, and then get you back to the workstations with the hands-on, and let's get started. So we're going to talk briefly about left atrial clipping and what you can do with CT to help people. We're going to spend a little more time on left atrial closure. We again got some really great morning lectures, and so you're experts now, so I don't have much to do. But I'd like you to actually work through some cases. So edge-to-edge repair of the mitral valve was very confusing to me. I had no idea why you would do this, why it would be helpful, how it would work. But effectively, when a surgeon, as you get functional and as the annulus gets bigger, it pulls the leaflets apart, and so they start leaking. So surgically, the goal was to make the annulus smaller. When you do the clip, you're basically pinning together the valve to bring it closer together, to make the coaptation zone close, and you're effectively closing it permanently, or hopefully permanently, with the idea that you will have as these two orifices on either side where blood goes through, and you'll have less regurgitant jet. So that's in theory how it works. Now, how they actually do it is largely based, as most of you know, on echo, both before the procedure and then TEE during the procedure. So we're not going to get into that. But you can see here from the MitraClip things that are important and that favors device selection are related to like how long the leaflets are, how big the clip device is, and then there's some other things that may be difficult to see at TEE that CT can help with. And so those things are, you can get the diameter or area of the mitral valve. You can look at the length of the anterior and posterior leaflets. The most important thing that you can often do is look at mitral annular calcification, because CT is very good at seeing calcification. So you can score the amount of mitral annular calcification, and you can also see small calcifications on the leaflet. So all of this can be obtained pre-procedure, or even from a CT that you may already have for some other reason. Let's say the person got a coronary and you're doing a clip. Sometimes they'll call me up and, hey, look at this. What do you see? Do you see this, that, and the other? The other things that you can do is just the size of the left atrium and help with puncture planning, other geometry, other odd things like, do they have situs inversus? Is one of their lungs collapsed? Is the heart at a completely different angle than what you would expect? So all of those things can be helpful. We've already talked a lot about left atrial appendage closure. So Alex gave some great lectures. There's this great radiographics article that has a lot of pictures to remind you what thrombus looks like, say, in the left atrial appendage, and what these devices look like. And the link is down here at the bottom. And again, you can pull this up when you get home. We talked a little bit about the idea of slow flow, okay? When people have large left atrial enlargement, it's not unusual for contrast to take some time to fill the left atrial appendage. So you will often see this appearance where there's incomplete filling, and you don't know on that first pass whether there's clot there. The whole thing could be clot, part of it could be clot. You can do things with measuring Hounsfield units, but you're probably not going to be convinced by that. The best way is to do a second pass at a delayed time of anywhere from 15 to 20 seconds, and you'll see that that left atrial appendage fills with contrast. And you can then interrogate the whole length of the appendage and say, hey, there is not thrombus, but there is reduced flow. I want to talk briefly about the other device, which is surgical closure. And so they have these Atria clip devices where you'll see this like big clip here. And I was talking with Alex during lunch. If you do CT, you will see people with these devices. They will come in and they'll get PE scans, they will get aortic scans, they'll get coronary scans. I had one over the weekend where they kind of missed or angled the left atrial appendage. So there was an accessory leaflet that wasn't covered by the surgical clip. So just be aware that these clips, you will see, whether you're doing just regular radiology, cardiac radiology, because these people get CT'd a lot. I'm going to skip over this, but this is another schematic just showing how you do the transeptal and deploy these devices in the left atrial appendage. I will say at Vanderbilt, the predominant device that we've seen deployed is the Watchman. We have some Amplatzers. We had several years ago, they were doing the Lariats. I think those have pretty much fallen by the wayside. I haven't seen one of those in a while. I think Alex already mentioned this. Where you land the device depends on the device itself, and you use this landing zone to figure out how big a device you need to put in. You want to measure the ostia, and this is what we're going to do. We're going to pull up a case, and you're going to find the left atrial appendage ostia, and I'm going to show you how to measure it. And then we're going to measure, like for an Amplatzer here, where you go from the ostia of this appendage and you go back in a little bit more. If you do a Watchman, you go up 10 to 20 millimeters and you angle this and you get this landing zone here. So we're going to show you how to do that and how to do that. So that's what we're going to do right now.